Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotation and you are more comfortable in caring for the critically ill patients. In this video, we will be discussing management of respiratory failure. I talked about the physiology, the causes, and diagnostic workup of respiratory failure in a separate video titled Part 1. If you have not already watched it, I highly recommend that you check it out. Link will be on the screen. If not, I will leave it in the description below. Let's start with the clinical scenario. Imagine you're a resident on internal medicine service and you have a patient who just arrived to the floor. Patient says he's really short of breath, is in obvious respiratory distress, and you grab a set of vitals and notice that he is hypoxemic and tachypneic. What do you do next? You can do things like get a chest x-ray, get an ECG, order a blood gas. While all of these are important, none of these are the immediate next step. The immediate next step is you have to provide supplemental oxygen to improve the patient's SpO2. There are various options to provide supplemental oxygen. Which one of these devices will you pick to provide supplemental oxygen to the patient we just discussed? If you are not very sure, do follow along and we will discuss the answer towards the end of this video. There are two crucial aspects of managing respiratory failure. One is providing supportive care, and two is treating the underlying cause. While both are very important, supportive care is often the more urgent and life saving intervention. Here is why correcting hypercapnia and hypoxemia immediately with supportive care is so important. Hypercapnia can have several downstream effects like cerebral vasodilation, increased intracranial pressure, encephalopathy, myocardial suppression, and acidosis. In the extreme state, it can cause cardiorespiratory suppression, coma, and death. Every cell in the body needs oxygen for metabolism, so when there is low oxygen, there can be multi organ failure and death. Certain tissues, like the brain, are extremely sensitive to hypoxemia. Even 5 minutes of low oxygen can cause irreversible neurological damage. Some other tissues, like the skeletal muscle, can survive up to 30 minutes with low oxygen. There are several causes of respiratory failure. We discussed the diagnostic approach and etiology of respiratory failure in detail in part 1 video. If you have not watched it, again, I highly recommend that you check it out. Discussing the treatment of every single cause of respiratory failure is way beyond the scope of this video. Today, we will talk mainly about supportive care. There are several devices available to provide supportive care for respiratory failure. We will discuss how each of these devices work, their advantages and limitations, so that you can pick the right device for your patient. Let's start with supplemental oxygen. There are three fundamental concepts to understand here: the FiO2, the flow, and PEEP. FiO2 basically is the fraction of oxygen in inspired air. It's commonly expressed as either percent or as a decimal. For example, ambient air has 21% oxygen or 0.21. One thing to keep in mind here is the amount of oxygen that we are providing with the supplemental device may not be the same as the patient is getting at the alveolus level. For example, if we are providing 100% oxygen through this device and this is mixing with a lot of ambient air, that's going to dilute this 100% oxygen, and the final concentration of oxygen reaching the alveolus will be less than 100%. Next, let's talk about flow. Flow is basically the velocity or the rate at which oxygen is going into the lungs or air is moving into the lungs. When we are inhaling at rest during normal inspiration, the flow rate can be up to 30 liters per minute. And that number is going to be much higher in a patient with respiratory distress or anytime during stress. For example, young men have been shown to generate inspiratory flow rates up to more than 100 liters per minute during peak exercise. Now, keep in mind, flow is different from minute ventilation. Both are expressed in the same units, liter per minute. Again, flow is the rate at which air is moving into the lungs. Minute ventilation is the absolute quantity of air, the total volume of air that we are inhaling in a minute. So flow is, in a way, velocity or movement of air. Minute volume is the total amount of air or the absolute quantity of air inhaled in 1 minute. There is a wide range of flow that we can use with supplemental oxygen device. It depends on the device you pick, but any device that provides less than 15 liters per minute flow is called a low flow device, and anything more than 15 liters per minute qualifies for a high flow device. We will discuss the details of PEEP in a subsequent slide. Let's discuss individual devices, starting with the nasal cannula. So FiO2 of air that is moving through the nasal cannula is 100%. It does not provide any PEEP effect. So the only thing we are controlling pretty much is the flow. So the range of flow through nasal cannula is 1 to 6 liters per minute. Now, for every 1 liter per minute flow, roughly the FiO2 of oxygen at the level of alveolus increases by 4%. Now, let's say you put a patient on 2 liters per minute via nasal cannula. So 2 multiplied by 4 is 8. Add that on to room air, which is 21%. So the patient is getting roughly 29 or 30% FiO2 at the alveolus level. Now, that is a very crude number, because as the patient is breathing air through the cannula, patient is also inhaling ambient air. Let's say this patient is inhaling at a peak inspiratory flow rate of 20 liters per minute, out of which 2 liters per minute is going through the nasal cannula. So that is only 10% of the entire air that is moving into the lungs. So 10% from the nasal cannula and 90% ambient air. So this is going to be really diluted. Now take that in a patient who is in respiratory distress and is breathing at, let's say 60 liters per minute. That dilution factor is going to be much bigger. So the effective FiO2 at the level of alveolus is going to be much lower in a patient who is in respiratory distress. That's a major limitation of nasal cannula. However, it has several advantages. Excuse me. It is simple and easy to use, meaning, you don't need complex equipment like you need with non-invasive ventilation. You don't need to know a lot of settings like you need with, let's say, mechanical ventilator or BiPAP machine. All you're controlling is the flow rate. It is easily available. Nasal cannula is available in the ERs, it's available in ICU, in the hospital floors, and several clinics. And so it's available everywhere. It is comfortable. You're not putting a tube down the patient's throat, you're not putting a tight fitting mask. It is comfortable to wear, and it is inexpensive. So due to all these advantages, nasal cannula is probably the most commonly used device for supplemental oxygen in the hospital. However, it has some important limitations. FiO2 at the level of alveolus fluctuates depending on patient's respiratory effort. So a set FiO2 at the level of alveolus cannot be guaranteed, as we already discussed. FiO2 at the level of alveolus also decreases in patients breathing through the mouth, because there's a lot of mixing of ambient air in that setting. Finally, beyond 6 liters per minute, it is difficult to maintain humidification through a nasal cannula. So the dry air going in makes it very uncomfortable, and also the FiO2 is not going to be reliable after 6 liters per minute. So if the patient is on 5 to 6 liters per minute and SpO2 is still low, then we need to look at alternative options. Next, let's discuss simple face mask. Similar to nasal cannula, the FiO2 of air going through the tubing is going to be 100%, and this does not provide any PEEP effect. So the only setting we control is the flow. The range of flow with a simple face mask is between 5 to 10 liters per minute. But even at 10 liters per minute, that is not going to be enough to meet patients' peak inspiratory flow demand, which will be upwards of 20 liters per minute. So simple face mask has these holes or perforations which allow ambient air to enter. So there is mixing of 100% oxygen and ambient air. Again, with every 1 liter raise in the flow, FiO2 at the level of alveolus is expected to increase by 4%, but this number changes wildly depending on patient's respiratory drive. Compared to nasal cannula, a face mask has these following strengths and limitations. You can achieve higher flow rates up to 10 liters per minute, so theoretically higher FiO2 at the level of alveolus. This is better in patients who breathe through the mouth because there is less ambient air entering through the mouth. But one issue with face mask is that it interferes with drinking and eating. The next higher level of support you can provide is a Venturi mask, and it works based on Bernoulli principle. If you push 100% oxygen through a narrow channel, then it creates a low pressure environment distally that entrains ambient air entering through the adjoining aperture. So by varying the diameter of this aperture, you can precisely control the pressures distal to it and therefore precisely control how much mixing of the ambient air is happening. So that is the advantage of Venturi mask. So a Venturi mask basically comes with these various valves which have fixed diameters and therefore decide how much FiO2 is going towards the patient. So the advantage with Venturi mask again compared to the other two devices we discussed is that you have better or precise control on the oxygen that is going to the patient. Now, in the recent years, as high flow nasal cannula is gaining popularity, Venturi mask is somewhat falling out of favor. A non-rebreather mask is another popular device, especially used during emergencies. 100% oxygen is provided through the tubing at a fixed rate of 15 liters per minute. But instead of going straight to the patient, it is connected to a reservoir, which is basically an expandable bag which can hold up to a liter of air. So when the patient is breathing in, he is breathing in 100% oxygen through this bag. When the patient is breathing out, the air is let out through these one-way valves which only allow air to go out but not in. So there is minimal to no mixing of the ambient air. So this is a brilliant design that can achieve effective FiO2, meaning FiO2 at the level of alveolus up to 95%. There can be still some mixing of the ambient air due to improper seal, so there can be a little bit of dilution, but FiO2 reaching up to 95% is a major advantage with this non-rebreather mask, making it a very potent tool for supplemental oxygen. We are now getting into more advanced form of support. A high flow nasal cannula is recognized by its large bore that delivers heated and humidified oxygen to the patient. Humidification is a more efficient process at high flows, which really contributes to patient comfort. But perhaps the biggest advantage of this device is its ability to generate high flows. You can reach flows up to 60 liters per minute. So far, the devices we discussed previously delivered flows up to 15 liters per minute, but this can generate much higher flows. We will look at the importance of that in the next few slides, but high flow nasal cannula is such a potent device that you don't have to use 100% oxygen. In fact, you can dial down the knob here to adjust the FiO2 between 21 to 100%. All the devices we previously discussed have a set FiO2 of 100%, but here you can actually go down on the FiO2. So two settings we control are the FiO2 and the second is the flow. The high flow gives this device two major advantages. First is flushing out of the dead space. Second is PEEP effect. Let's look into these in detail. We discussed dead space in more detail in the part 1 video, but dead space is basically all the air contained in airways which is not participating in gas exchange. So basically the nasal passages, the pharynx, larynx, trachea, bronchi, all these chambers constitute dead space. By providing supplemental oxygen at a high flow, you're able to flush out and replace all the ambient air in these dead space areas with fresh oxygen. That's also shown in the figure here. By going up on the flow, you're able to completely replace the ambient air in dead space. Ambient air here is represented in blue, and fresh oxygen that you're providing through the high flow cannula is white or transparent. So that fresh oxygen is directly available to go into alveoli and participate in gas exchange. Now let's discuss the PEEP effect. The three fundamentals of oxygen delivery again are FiO2, flow, and PEEP. During normal respiration, the alveoli are filled up with air, they expand during inspiration and they shrink during expiration. They shrink but they don't completely collapse. They have surfactant lining the alveoli which prevent them from collapsing. They reduce the surface tension. But that changes when you have a disease process like pneumonia or pulmonary edema where the surfactant is destroyed or damaged. So these alveoli tend to collapse during expiration. And if the disease is advanced enough, they remain collapsed during inspiration as well. And therefore, they're not participating in any gas exchange, contributing to hypoxemia via shunt physiology. Again, this was discussed in detail in part 1 video. What you're doing with PEEP is that you're providing an opposing force which prevents collapse of these alveoli during expiration. So PEEP again stands for positive end expiratory pressure. So if you provide a positive pressure that is keeping the alveoli splinted open during expiration, they are able to participate in gas exchange. Therefore, you're making these diseased alveoli again available for gas exchange. In other words, you are recruiting the alveoli. So PEEP is a very powerful tool that can help improve oxygenation by mechanisms beyond FiO2 and flow. A high flow nasal cannula, by virtue of its high flow, can provide a weak PEEP effect up to 4 to 5 centimeter water pressure. Non-invasive ventilation using modes like CPAP and BiPAP can provide up to 20 centimeter water pressure of PEEP. Invasive mechanical ventilation can provide a very high PEEP up to 30 centimeters, and if you really know what you're doing, you can go beyond 30 centimeter as well. But don't do that without consulting with your attending physician. Next, we will discuss non-invasive ventilation. Let's review indications and contraindications for NIV. Hypoxemia that is refractory to less invasive forms of support would be one indication for NIV. NIV is typically not the first device we go for because it is fairly complex equipment, it is expensive, needs an expert like a respiratory therapist to maintain it, and it is also not very comfortable, right? You're putting a tight fitting mask on patient's face. So for all these reasons, we typically don't pick NIV as the first device of support. But if hypoxemia is not responding to other less invasive forms of support, then you want to consider NIV. Then hypercapnia associated with respiratory acidosis would be another indication for NIV use. All the devices we talked up until now only provide supportive care, except NIV, which can also assist with CO2 removal. There are some specific disease states where NIV is well studied and is associated with potential mortality and morbidity benefit. Examples are COPD exacerbation, pulmonary edema, OHS, OSA, and neuromuscular disease. In these conditions, you want to try NIV unless there is a need for urgent intubation. Contraindications. Really, there is one main contraindication to keep in mind, which is if there is a need for urgent intubation, you want to go straight for intubation. You don't want to mess with NIV. For example, take a patient who has anaphylaxis, is having worsening upper airway swelling, is wheezing, is in respiratory distress. You don't want to put this patient on NIV and hope for the best. You want to go straight for endotracheal intubation. There are some other relative contraindications. Encephalopathy, for example. Some confusion is okay, but if the patient is extremely obtended, you want to think twice before putting NIV. Because let's say that patient starts to vomit. Unless that patient has the mental status and dexterity to pull off the mask or ask for help, the patient is going to aspirate those, the vomitus and land in trouble. Facial trauma or facial surgery, obviously you don't want to put pressure on it. Also, whenever there is an airway obstruction like a laryngeal tumor or again anaphylaxis, angioedema, NIV is not going to work. Then if there is recent gastric or esophageal anastomosis, then if this patient has aerophagia, meaning a lot of air entering the esophagus and stomach, that can stretch the anastomosis and cause problems. So these are some contraindications to keep in mind before putting your patient on NIV. Once you decide to place your patient on non-invasive ventilation, there are three important decisions you have to make. One is the interface, two, the mode, and three, the settings. Let's start with interface. Interface is basically the piece that connects to the patient. As you can see on the screen, there are various types of interfaces available, and there is no one device that is clearly superior to others. So, what device we pick depends on factors like availability, which device gives the best fit and seal, and which device the patient feels is most comfortable to them. Generally speaking, oronasal mask is the most common or a very popular type of interface. There are multiple modes available, but CPAP and BiPAP are the ones most commonly used. CPAP stands for Continuous Positive Airway Pressure. As the name suggests, the machine tries to maintain a constant pressure and doesn't change it between inspiration and expiration. At the upper airways level, CPAP keeps the upper airway splinted open, so it treats OSA. At the lower airways level, it does the same job as PEEP, so improves oxygenation. The range of pressure on CPAP is 5 to 20 centimeter water pressure. The second setting we control is the FiO2. When treating respiratory failure, we typically start at 100% and gradually down titrate as tolerated. Benefits of CPAP, as we discussed, it treats OSA and PEEP improves oxygenation. For BiPAP, similar to CPAP, we start with an FiO2 of 100% when treating respiratory failure and down titrate as tolerated. Let's understand the pressures of BiPAP. There is something called EPAP, which stands for Expiratory Positive Airway Pressure. For practical purposes, this is the same as CPAP. So at the upper airways level, it splints open the airways, treats OSA, and at the lower airways level, it provides a PEEP effect and improves oxygenation. The special thing about BiPAP is that whenever patient starts to take a breath, the machine can sense that and it ramps up the pressure to a set level called IPAP or Inspiratory Positive Airway Pressure. The difference between IPAP and EPAP is called delta PAP or sometimes known as pressure support. So the way the machine increases the pressure in the lungs is by pushing tidal volume or volume into the lungs. Now let's say I leave the EPAP the same and I go up on the IPAP. So the machine now has to push more air to reach that higher level of IPAP. So larger the delta PAP means larger the volume being pushed by the machine into the lungs. So that's an important concept to keep in mind. Additional settings to know for BiPAP are related to the respiratory rate. So there is something called spontaneous mode, meaning every single breath is initiated by the patient. The machine simply supports the breath with delta PAP. Second is a timed mode where you can set a respiratory rate. Let's say you set a rate of 10 breaths per minute. So every 6 seconds, the machine increases the pressure from EPAP to IPAP, meaning it pushes air into the lungs. So that the patient is getting a breath at least every 6 seconds, which will be 10 breaths per second. Per minute. But the one we commonly used is something called spontaneous/timed mode, where you can set a rate. Let's say you set a rate of 10 breaths per minute. So every 6 seconds, the machine does push a breath if the patient is not breathing. But if the patient is breathing above that rate, let's say patient is breathing at 16 breaths per minute, the machine simply supports each of those breaths by ramping up the pressure or pushing air into the lungs. So the advantages of BiPAP are: one, the EPAP part of it works similar to CPAP. It treats OSA and it provides PEEP effect and improves oxygen. The delta PAP increases tidal volume, and using the T mode or the timed mode or spontaneous/timed mode, you can also control the respiratory rate. So with BiPAP, you have much better control on the minute ventilation. So by increasing minute ventilation, you can treat hypercapnia. You can also decrease the workload on the patient's breathing muscles. All the devices we discussed so far come with adjustable levels of support except for a non-rebreather mask where FiO2 is fixed at 100% and flow is fixed at 15 liters per minute. So how we titrate the support depends on the goals of treatment. So when treating hypoxemic respiratory failure, for most patients, the goal is 90 to 96%, or the SpO2 goal is 90 to 96%. There are exceptions like ARDS where slightly lower level may be okay, or in patients with chronic hypercapnic respiratory failure, also more than 88% should be okay. When treating hypercapnic respiratory failure, the goal is to bring down the CO2 to less than 45 millimeters of mercury or to the baseline value in case of a chronic retainer. The more important number to focus here would be the pH, as the goal of treating hypercapnia is to correct the respiratory acidosis. Now let's quickly summarize the settings we can adjust for each device. For low flow oxygen support, only setting we can adjust is the flow. For example, nasal cannula and simple face mask. For a high flow system, we can adjust flow and we can also adjust FiO2. For NIV, if we want to improve hypoxemia, we can adjust CPAP same physiologically as EPAP or PEEP, and we can also adjust FiO2. If our goal is to reduce hypercapnia or improve work of breathing, we can go up on the delta PAP, or we can increase the respiratory rate on a T or S/T mode. The next level of support is invasive mechanical ventilation. This is a pretty broad topic, so I have made a separate video where I reviewed the indications for intubation, I discussed how a ventilator works, and I discussed the process of initiation, maintenance, and liberation from a mechanical ventilator. Do check it out. The link should pop up on the screen. If not, I will leave it in the description below. Now let's discuss the scenario we talked about at the beginning of this video. How do you support this patient who is in respiratory distress and is severely hypoxemic? All these devices provide supplemental oxygen, and there is not necessarily a wrong answer here, but it's more about what is the most appropriate form of support. In my opinion, the most appropriate form of support for this patient would be a non-rebreather mask. The reason being, it is a very potent device. The effective FiO2 at the level of alveolus can reach up to 95%. It is also a very simple and easily available device, compared to, let's say, a high flow or non-rebreather. If you pick high flow, you have to decide what FiO2 and what flow you are going to be using. If you pick non-invasive ventilation, you have to decide FiO2, the CPAP or EPAP and IPAP, and you usually need a respiratory therapist to help set up the equipment. Versus a non-rebreather mask, where all you have to say is put on a non-rebreather mask. You don't even have to think about any settings. The flow is fixed at 15 liters per minute. The FiO2 is fixed at 100%. The only caveat is if it's a dire emergency like cardiac arrest or a severely obtunded patient who is starting to vomit, in situations like that, securing the airway with an endotracheal tube is urgent, and none of the other forms of support would replace that. So unless the patient needs urgent intubation, generally speaking, in acute situations where patient is in respiratory distress and severely hypoxemic, non-rebreather mask is a good starting point. And if it is too much support, let's say, few minutes down the road, patient is satting 100% and is not in any distress, then you can always downgrade the support. But what you don't want to do is start with a nasal cannula or a face mask and few minutes later see that it's still not enough, then go up on the support. You're wasting precious minutes there. So that's why non-rebreather mask in situations like this is a good starting point. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from it. Finally, I would love to hear your thoughts. Is there any part of this video that you found particularly helpful? Is there anything I could have added to make this more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.